Good evening, everyone. Welcome to the Webisode 34 of Decoding GI-HPB Oncology. I'm sure most of you would be now aware of this program. This is a fortnightly program where we focus on basics of GI-HPB Oncology. And this time we are talking about surgical management of gastrointestinal stromal tumors. And we have a esteemed panel here. We have Dr. Sanjiv Haribhakti, who has been teacher to many of us, and he's a well-known figure. He practices in Ahmedabad. He has written a couple of books, and he will be taking a lecture followed by a panel discussion. So panel discussion will be moderated by my colleague, Dr. Suresh, and we have panelists from all across the country. So we have Dr. Premananda Patnaik, Dr. Anand, and Dr. Basant, and Dr. Alok. So Dr. Patnaik is from Bhubaneswar. He has done his MCH from AIIMS and now practicing as a GI surgeon in Bhubaneswar. Dr. Anand is faculty at AIIMS New Delhi, and Dr. Basant Singh is at AIIMS Patna, and Dr. Alok Ranjan is at IGIMS Patna. So with this, I invite Dr. Sanjiv Haribhakti to deliver the lecture. Sir, please.
Thanks, Nikhil. Thanks for that kind words. And the topic that is given to me is GI stromal tumors. We have a very elite, fantastic panel from the All India Institute all over the country to moderate. So I won't take too much of time. What I'll do is I'll give an overview of GIST, and then we can discuss a lot of controversies in the panel. That is how I would like to take this topic. It's a very, very interesting subject. There are a lot of recent advances. Our understanding, our knowledge about GIST keeps changing. I hope you are able to see the presentation, Nikhil. Can I go ahead?
Yes, sir. Go ahead.
Okay, fine. So GIST is overall, if you see, it's a rare cancer of the GI tract. Almost 1% of all the GI cancers. But amongst the mesenchymal tumors of the GI tract, it's 90 per million of population. And the cell of origin of GIST was debated for a long period of time, but now it's known that it starts mostly from the ICC, the interstitial cells of Kajal. And it is reported in all age groups. It even occurs in the pediatric population. The incidence increases with age, but most of the patients do present at the 60 to 70 years of age, and male and females are equally affected. If you look at the anatomical location, almost more than 50% of the GI GISTs, they occur in the stomach. Small bowel is the next. Almost 28% of GIST occurs in the small bowel. And then there are these less common locations like esophagus, duodenum, colon, and rectum. Rectum is a commoner location than the colon. And then some of these patients may present, almost 9% may present with metastatic disease, disseminated tumors, liver mets, sometimes even lung mets, where we sometimes don't know where the primary is. And apart from the stomach, there are apart from the GI tract, there are extraintestinal locations where GIST can arise. This is not so common. Almost just 5% of all the GIST arise outside the GI tract, and they occur in the pancreas, the retroperitoneum, the mesentery, and the omentum. So these are much less common. And many of these are larger in size. They have a higher malignant potential, early onset of disease, and they have a poorer prognosis than the GI GIST. The definitive diagnostic criteria are the immunohistochemistry, histology, and the risk stratification, which are very similar to those of the intestinal GIST. Pediatric GIST is another a very different domain. Just 1% of all GIST occur in the pediatric age group. It is rare, but these GISTs are different from the adult GIST in which the KIT PDGFR mutation is much less common. And majority of these are wild type. They are wild type GIST. They don't have the c-KIT or the PDGFR mutations as seen in the adult GIST. Females, it occurs in more common in females. They are multifocal. They have a higher lymph node spread. And there are two syndromes which are common with the pediatric GIST. One is called the Carney triad. 15% of. I'm getting some disturbance. Can you mute all the other participants, please? Yeah. So Carney triad, where GIST occurs with paragangliomas, with pulmonary chondroma, this is about 15%, and Carney-Stratakis syndrome, which is also called the Carney's dyad, where GIST occurs along with paraganglioma. Majority of the GIST have spindle cells. They are, the classical spindle type, spindle-shaped cells in whorls, and most of these GIST, which are low-risk gastric GISTs, they are mostly c-KIT positive, and they are more commonly seen in the stomach. Some of the GISTs have epithelioid cells. They are the round cells with a very clear cytoplasm, and these are the intermediate or the high-risk GIST. And the ones with exon 9 mutation is more common and occurs more commonly in the small bowel. These exon 9 mutations are different because they are more resistant to imatinib, and that's why they form a very different kind of a genetic predominance. And then there could be mixed spindle and epithelioid cells. The immunohistochemistry has come up as the most important way to determine GIST, and today, for confirmation of the GIST, IHC markers in the form of CD34, CD117, which is called the KIT mutation or the c-KIT mutation, and the DOG1 mutation. These are the commonly done tests which are done. And for excluding GIST, desmin, vimentin, and S100 are the markers. The combination, almost CD117, 95% of the GIST, they show this mutation, and DOG1 is seen in about 95%. And the combination of both occurs in about 98% of GIST. So if both these are negative, then GIST is almost unlikely, less than 2%. And that's why the KIT mutation, that is the CD117 and the PDGFR, the platelet-derived growth factor mutation, is considered to be the hallmark in the diagnosis of the GIST, and the desmin and the S100 are considered to be the hallmark negative factors in the diagnosis of GIST. So this is how GIST is differentiated from leiomyomas, leiomyosarcoma, schwannomas, and desmoid fibromatosis, which are the important differential diagnosis of GIST tumors. Now, these are some of the genetic, syndromes, because GIST expresses a lot of exons and mutations, and that is how, there are several types of syndromes which have been described, different mutations. The most common mutations are on the exon 13 and the 17 of the KIT mutation, and sometimes with PDGFR mutation, some of them are wild type GIST. Many of these are, they're deficient in succinyl dehydrogenase SDH deficient GIST. So there are several of these mutations. We're not going into details of these mutations, but at least we must understand that there are several genetic syndromes associated with GIST. Coming to the clinical presentation, some of the GISTs are picked up as asymptomatic GISTs on routine ultrasound evaluation for some other condition. Almost 10 to 20% of GISTs are picked up asymptomatic. Some of the patients present with bleeding, that is the commonest manifestation, GI bleeding. Abdominal pain can be there, but sometimes it is not specific. Rarely some patients present with rupture or perforation, bleeding or obstruction leading to acute abdomen. And altered bowel habits is a symptom of rectal GIST, dysphagia for esophageal GIST, and incidental detection in about 15 to 20% of patients. So ultrasound is the screening test. It will detect that there is some tumor in the bowel or in the abdomen. And CT scan is the most definitive because CT has definitive criteria for diagnosis. MRI is equivalent to CT scan, and that's why there is no additional benefit of MR. EUS is used generally to take biopsies or cytologies, but biopsies are better because that gives us the IHC markers. And PET-CT, I'll come to that, how PET-CT, what is the role of PET-CT. So essentially, these investigations are used in diagnosis, in staging of the disease, sometimes after an adjuvant treatment in restaging, and response to treatment when these patients are on adjuvant or neoadjuvant treatment, and for follow-up surveillance, as these patients have a tendency to recur. This disease has a quite high tendency to recur locally. So this is the classical appearance of a CT. As you'll see that there will be a large tumor. Majority of these are large tumors. It's like a fleshy mass in the either arising from the stomach or in the bowel. And typically with the larger tumors, there will be some areas of central necrosis or hemorrhage with the variegated appearance morphology. And on a contrast, we'll see that there will be some enhancement also on the gist. And it's a hypervascular enhancing mass with heterogeneity. And features are mainly the large size, the sharp demarcation from the surrounding infiltration of the surrounding structures may be present, and sometimes they may cause metastasis to the liver or to the other structures. So CT scan is a must following endoscopic detection of the gist. Sometimes they may be detected on an endoscopy where we may find a submucosal kind of a mass, but generally these have a larger exophytic component, and that's why CT scan must follow the endoscopic evaluation. Now PET-CT is an important test, especially for large or advanced tumors, metastatic tumors, because on the PET-CT, it has a very high uptake SUV, and this FDG avid is because of the receptors that are present on the c-kit. And this is not a substitute for CT scan, but they may be indicated for neoadjuvant treatment, baseline for a metastatic disease, for following response to chemotherapy, and to determine the response. So endoscopy will show a smooth surface. There will be submucosal bulge. There may not be any ulcer, but sometimes they may perforate, they may have an ulcer, and they may bleed also. An endoscopic ultrasound, you'll see that these are cystic spaces, irregular borders, echogenicity, and biopsy is generally required. It's generally not required to diagnose gist, but sometimes in a smaller tumor, one may need a biopsy to confirm what is the kind of tumor. So for all operable lesions, which are generally more than 2 centimeters, are an indication for surgery. Biopsy is not necessary for operating these patients. Endoscopic biopsy can be taken from the edge of the ulcer when we see an ulcer. But otherwise, if there is no ulcer, then the best way to take a biopsy, if it is necessary, is to do a US guided biopsy. And this reduces the bleeding risk and increases the yield because these are all submucosal lesions. So gist has a malignant potential. There is a higher risk, almost a 30 to 50% risk of recurrence. Most of the recurrences are local recurrences, but sometimes they also develop metastasis. They are generally slowly growing tumors, but recurrences are quite common. And gastric gist on an overall is less aggressive than other bowel, small bowel, large bowel, or upper GI gists. And not a single risk scoring system is very accurate. The important prognostic factors, the size is one of the most important prognostic factor. Generally, it is taken more than 2 centimeters cutoff, but for the gastric gist, it is a 5 centimeter cutoff. The mitotic rate, I'll come to that. Tumor rupture, location of the tumor, gastric or extragastric or intestinal or extraintestinal, and the presence of R0 resection, or if the margins are positive, then these are some of the prognostic factors which will cause an increased risk of recurrences. And based on these 3 prognostic factors, the tumor size, the mitotic index, and the primary tumor site, there are several risk categories which have been identified to determine the risk of recurrence after a surgical resection in gist based on very low risk, intermediate risk, or high risk. So in general, more than 2 centimeter, less than 2 centimeter is a low risk gist, with a less than 5 mitotic index per 50 high power field are generally considered to be low risk. But more than this, and especially more than 5 centimeters for stomach, are considered to be high risk, and these high risk are further subdivided into intermediate and the high risk. So essentially, most of the times adjuvant therapy will be needed for high risk of gist recurrence. If the gist recurrence is considered to be more than 30%, then definitely an adjuvant treatment will be necessary in the form of imatinib. Now, these are the several in different criteria, different what are the very low, intermediate, and high risk groups. The red forms the high risk group, the yellow is the intermediate risk, the blue is the low risk, and green is the very low risk. You'll see that in several different series, by and large, about 30% on an average, 20 to 30% will be high risk gist, almost 10 to 20% will be intermediate risk, about 30% will be low risk, and about 10 to 15% or maybe up to 20% will be a very low risk of gist. Based on these risk criteria, MSKCC has developed a prognostic normogram, which will help us based on the points given by the size, by the mitotic index, and from the site. You can actually determine the exact total point score, and we can determine the probability of a 2-year recurrence-free survival and a probability of a 5-year recurrence-free survival based on these normograms. So one can plot the size, one can plot the mitotic index, plot the site, and get the total score, and then based on this determine what is the 2-year and the 5-year recurrence-free survival estimated. And based on that, you can take a decision whether you need adjuvant treatment or not. Now, malignant potential of GIST is definitely is there based on the size and the mitotic index. And based on this, the risk of recurrences may be higher than 50% in high-risk groups, sometimes with a higher mitotic index. And more than 10 centimeters with a high mitotic index, the risk of recurrence will be as high as 86%. And that's why we now have very effective treatment, adjuvant treatment, and that's why we should judiciously use the adjuvant therapy to reduce the risk of this recurrence. So surgical management of the GIST is the most curative treatment for GIST, and all GIST require surgical excision except those which are less than 2 centimeters without any high-risk features, less than 5 mitotic index. Then they can be observed. Principles of surgery are that one should do a wedge resection or a local resection without rupturing the tumor. One should not do a enucleation because there is a high risk of rupture. It's better to do a segmental or a wedge resection of the stomach or a localized resection of the small bowel. Complete excision with a capsule with at least a 1 or 2 centimeter margin. What we need is a clear margin. A larger or longer margin is not necessary, but at least a clear 1 centimeter margin is good enough. There is no need for any lymph nodal resection. If it is a gastric tumor, you don't need to do any D1 or any lymphadenectomies for GIST. Even if for a small bowel, you don't need to do mesenteric excision. For GIST, you can do a localized segmental excision. And the concept is to preserve the organ as much as possible. If it is a rectal GIST, we can do a resection and preserve the rectum, preserve the organ as far as possible. Sometimes this GIST may affect or infiltrate the adjacent organs, where one can use neoadjuvant treatment to reduce the risk, to shrink the tumors and to preserve more organs. So less than 2 centimeter stomach GISTs are less aggressive than small bowel or colorectal GIST, and these GISTs are called mini GIST. It's 1 to 2 centimeters, and less than 1 centimeter is called a micro GIST. So this can be safely observed. They are very indolent tumors. They are very slow growing tumors. And to look for, if you are going to conserve them, we should definitely look for we should do an EUS to look for high risk features, and then only take the decision. And surveillance is only done for less than 2 centimeter gastric GIST. And if they don't have any high risk features, those are the only areas where one can do surveillance. Rest all of the GIST will require surgical treatment. Now, there are several controversies with the GIST, associated with GIST. And one is what to do if when you resect and the margins come positive. So this is an area where we could do watchful waiting, wait for the recurrence to develop and then treat it, or give adjuvant treatment, or go ahead and do a re-resection. The jury is not out, and these are the areas which we could take up in the discussion or our panel. What is the role of laparoscopy in GIST? Something which is not very clearly established, but currently our thinking is that if it is not a very large tumor, say up to 5 or at the most 7 centimeters GIST, then it is definitely a good option to go ahead and do a laparoscopic resection, wedge resection, or whatever is needed. And then we can remove the tumor, or one could do a hand-assisted resection. But for very large tumors like 8, 10 centimeters tumor, does not make any sense to do laparoscopy, because anyway, we'll need an incision to remove the tumor. Adjuvant therapy has already been there for now more than almost 15 years now. But there is an evolution in the with the SSG trial, the Scandinavian sarcoma group trial. Now currently the adjuvant therapy, which was up to 2 years, now has been extended up to 3 years. The standard adjuvant treatment is to give imatinib 400 milligrams every day, and that is to be continued for 3 years. And most of the high-risk groups, intermediate risk groups and the high-risk groups will require imatinib. Only for the low-risk group we can avoid, or the very low-risk group we can avoid an adjuvant treatment, because the risk of recurrence will be lower than about 20%. And then now with the very large tumors, especially ones which are infiltrating the adjacent organs and in difficult locations like esophagus, lower end, GE junction, rectum, lower end of the rectum, and these kind of locations, sometimes stomach, posterior wall infiltrating pancreas, all these locations, it is a good idea to give neoadjuvant therapy. But at the same time, it is important to understand that even with larger GIST, say 10, 12, 15 centimeter GIST, if they are not, they are clearly resectable without much problem, like a gastric GIST, which is clearly resectable, then there is no point giving a neoadjuvant treatment. It is better to go upfront for resection and then give an adjuvant treatment in a situation where it is a clearly resectable. So neoadjuvant treatment is currently indicated for borderline resectable GIST, not for clearly resectable, even large tumors, 15 centimeter GIST. If it is clearly resectable, neoadjuvant treatment is not indicated, because neoadjuvant treatment then needs to be continued for at least 6 months, sometimes even 12 months to get a good tumor response. And then, sometimes these tumors may respond, sometimes they may not respond also. But it is known that the tumors which are responsive to neoadjuvant treatment, which have a stable disease, or which is a responsive disease, where there is a significant shrinkage of the tumor, then these patients have a better outcome. That is something that we know. So how do you assess the response to the adjuvant treatment or the neoadjuvant treatment? This is currently for all solid organs or for all solid tumors. It is by these RACIS criteria that we assess the response, whether it is a complete response with a disappearance of all lesions, no new lesions developing, partial response where the tumor size reduces by more than 30% and there is no new lesions, stable disease, there is no symptomatic deterioration, and progressive disease or progression of the disease where there is increase in tumor burden beyond 20% with development of the new lesions. So this is how we, even in clinical trials, the RACIS criteria is commonly used today to assess the response to the neoadjuvant or the adjuvant treatment. Now in the stomach, how these tumors should be treated. Small bowel is much easier, but the more common location is the stomach. More than 50% of the location of the GIST is in the stomach. So for the type 1 tumors, where they occur on the grid curve, they occur in the body of the stomach or in the fundus of the stomach, it is a good option to do a laparoscopic wedge resection. And this is a good option. If it is on the anterior wall, it is much more easier. One can elevate the lesion with the help of a bowel grasper and use the staplers to do a wedge resection, just like we do a sleeve operation for bariatric surgery. Even for a posterior wall tumor, there are 2 ways. One is that one can get into the lesser sac, divide the gastrosplenic and the gastrocolic omentums and get into the lesser sac, and then rotate the stomach and do a wedge resection, just like we do in the anterior wall. The other option is that we can open the anterior stomach, do an anterior gastrotomy, and then locate the tumor inside, take a suture and lift the tumor out, and then put on a stapler and then do it. For higher tumors, I think this will be a better option. For the lower tumors, getting behind into the lesser sac and doing a resection is a better option. For the type 2 type of tumors, which are more close to the pylorus and the antrum, wedge resection is not advisable because these patients may develop strictures in the antrum in the postoperative period. These are areas which are not very voluminous, they're not very, spacious, and that's why it will be better to do a distal gastrectomy, something like a Billroth 1 gastrectomy, and do a gastroduodenostomy. And this can also be very well done with laparoscopy. The most difficult kind of tumors are the tumors which are on the lesser curve, especially the high up, closer to the G junction. These are the tumors which are difficult to manage. And these tumors will definitely need a laparoscopic, sometimes a combined endoscopy, transgastric approach for doing a resection, one can go in and do a wedge resection. One can use the harmonic, remove it. If the stapler is not possible, because if it's too close to the G junction, it may not be possible to lift this tumor up and do a stapled or a wedge resection. Then one can resect the tumor with the harmonic scalpel and do a intragastric suturing with the laparoscopy and take out the tumor. So these are all the ways we can treat the gastric cysts. What is the post-operative surveillance? Generally based on the risk criteria. If it is a very high risk tumor, then a 3-monthly surveillance. If it is an intermediate or a low risk tumor, a 6-monthly surveillance for at least 5 years. History, physical examination, and a CT scan is a must because we won't be able to see. Endoscopy is not a good way of assessment. Unequivocal CT findings will need to be confirmed with the PET CT in the post-operative follow-up. And if it is a very low GIST, less than 2 centimeters, very low risk tumors, then one can reduce the frequency and do an yearly surveillance, at least for the first 5 years. So what to do if there is a microscopically positive margin for primary GI stromal tumors? A systematic review and meta-analysis suggests that R1 resection has a poor disease-free survival compared to R0, but there is no difference in overall survival. So even if there is an R1 resection, the overall survival is not very different. And this paper showed, this was from China, which showed that adjuvant imatinib could reduce the risk of recurrence for primary GIST with R1 resection. So that showed that adjuvant imatinib will have a benefit. But another large study which showed that imatinib does not work in a situation like this, and there was no statistically significant difference in recurrence-free survival with or without imatinib in patients who had a microscopically positive margins for primary GI after surgery. So there are conflicting evidence in the literature. We don't know what is the right approach. We can discuss this in the panel. Laparoscopy, we have already discussed how one should use it judiciously, not for very large tumors. Accessible locations are better to do laparoscopy using a specimen retrieval bag. Make sure that the tumor does not rupture while you remove it. Minimum handling to reduce the risk of rupture and recurrences are essential if we do it laparoscopically. So with this, I come to the end of the presentation. Thank you.
Thank you, sir. Excellent presentation, and you have almost covered everything in this. And I can see that you have made the life of Dr. Suresh difficult. He doesn't have many things to discuss after this, but it's a very good summarization. I think we can now move on to panel discussion, and Dr. Suresh will start the panel discussion. Dr. Suresh, please. Suresh. Suresh.
Sir, I'm just trying to share my screen. Just wait, sir.
If you have any difficulty sharing, you can ask me to do.
Sir, I'm not able to share my screen. Can you?
I will do it. Yes, I will do it. Don't worry. You have to ask me to move to the next slide. Is it visible now? Right.
Sir, are you able to see my screen, sir? Dr. Nikhil. So are you able to see my screen?
Yes, we can see your screen, Dr. Suresh.
Okay. Good evening, everyone. First of all, I would like to thank Dr. Nikhil for giving me opportunity to moderate this session. And I would like to welcome all the panelists, Dr. Sanjiv Haribhakti. First of all, they have summarized in a very good way this gist, and I think almost nothing has left to discuss now. And further, I would like to welcome Dr. Alok Ranjan and Dr. Basant Singh, Dr. Anand, Narayan, and Dr. Premananda Patnaik. Before starting my this presentation, I would like to thank Dr. Vivek Mangala. Also, they have helped me to find out the case for this to moderate this session. So, without wasting my time, I would like to quickly come to the case capsule and their discussion. So, my first case is a 54-year-old male. He presented.
Sorry to interrupt you. You'll have to start presentation mode. It will be better.
Okay.
You'll have to also, when you share your screen, you'll have to change it there also.
Is it okay?
No. Start the presentation mode, and then when you share a screen, there will be two screens. One will be this screen, and one will be the presentation screen.
Reading view, slide border.
Go to share screen. Once you have done started the presentation, go to share screen, and then you will see two screens. One is the full screen view, and one is a this view. So just choose the other view.
No, sir. First, I have to stop sharing the screen, sir. What to do?
You have to stop sharing and reshare the full screen.
No, just make a slideshow.
Okay.
Start the presentation on PowerPoint and then share the full screen.
मेरा आवाज वैसे जाएगा.
Dr. Nikhil, you.
I've shared. Start.
Oh.
Suresh, we can see the full screen now.
Let me check, sir.
I think everybody can see the screen, right?
Yes. Everybody.
Yeah. Dr. Suresh, just start.
But I'm not able to see the screen, sir. Just some issue is there, sir. Yes, it's okay. Sir, can you move on to the next slide, sir?
Yes.
Dr. Nikhil. So my first case discussion here is a 54-year-old male who presented with the right pain in the right upper abdomen, and he was evaluated with ultrasound, and it showed the acute cholecystitis. And on evaluation, in view of pain and everything was normal except he had a raised lipase level. So in view of raised lipase level, he was further evaluated with contrast enhanced CT scan to see the extent of pancreatitis. And CT scan showed the polylithiasis along with the enhancing polypoidal mass arising from the posterior wall of body or the stomach. Next screen, next slide, Dr. Nikhil. And this is a CT slide that's showing the enhancing mass arising from the posterior wall of the stomach along the greater curvature. Next slide, Dr. Nikhil. This patient was further evaluated with upper GI endoscopy and showed a hemispherical submucosal lesion, and endoscopic ultrasound showed dumbbell-shaped lesion arising from the muscularis propria. My first question to Dr. Basant is, what is the next step you will do in this case? Incidentally, mass found in the gastric lesion.
So, good evening, everyone. For this patient, I think the primary problem here is gallstone and the pain that is happening to him, and patient also has acute pancreatitis. So, I would like to address these issues first. Okay. So, after the pancreatitis settles down, and then if you're planning a laparoscopic cholecystectomy, then we should address the gist also, because as Suresh said that observation for gastric gist is only done for less than 2 centimeters, and all just have a potential to metastasize. So if at all we are, so this patient mandates surgery in my point of view. It's 3 centimeter gist at a favorable location in a young fit patient, and it's amenable for laparoscopic dissection. So I would consider surgery for this patient along with the stone disease.
Good, Dr. Basant, that Dr. Sanjiv Haribhakti have already described in detail that every gist tumor more than 2 centimeters we have to excise, except the tumor less than 2 centimeters we having no high risk feature for stomach can be observed. So my next question to Dr. Premananda, as we have seen, this is around 30 centimeter lesion in along the greater curvature. Which surgery would you prefer? Is it sleeve, Badger section versus gastrectomy? Dr. Premananda.
Good evening, everyone. As this is a very small tumor, I'll opt for laparoscopic OH resection or sleeve resection. But from the CT scan, the tumor has more of the endophytic components or more. So during laparoscopy, you may not visualize the exact area. So what you can do in this situation is preoperative endoscopy you can do and inject methylene blue transmurally around the lesion, so that the next day during laparoscopic surgery you can easily identify the area, and that area you can do the anterior gastrostomy, that perilesional methylene blue part which is stained, so that it localizes the tumor area, and you resect the tumor and you can suture it. Hand suture, laparoscopic hand suturing, intracorporeal suturing can be done. So that is one thing when the tumor has more of the endophytic component. If it is exophytic, you can go ahead with laparoscopic sleeve resection kind of thing. Any other opinion? Gastrectomy is not required.
So I think this is a small tumor and it is a posterior wall gastric lesion. So just we are focusing on the gist at the moment, not talking about cholecystitis or pancreatitis. I think there are 2 ways we can approach this tumor well. One is, laparoscopy is a good option, but with small tumors, it will be very difficult to visualize this from when we go into the lesser sec posteriorly. And that's why, either we end up resecting more of stomach or we end up leaving the tumor behind. And that's why I think 2 good techniques in this situation. One is that we can do an anterior gastrotomy, and then easily we can see the tumor. We can just lift it out, put in a stapler and resect it and close the anterior gastrotomy by sutures. So that is a very good, easy way of removing this tumor. The second way of removing this tumor is what is called as an intragastric surgery. So what essentially we can do is that we can lift the stomach up. There are this special balloon trocars, 5 mm balloon trocars can be put into the stomach, and then we can inflate the stomach and create a pneumoperitoneum into the stomach. So it's a pneumogastrium. And then within the stomach, we can go in and use our harmonic scalpel and resect that tumor and do suturing and suture that defect. So this is another very good way. If you are using only 5 mm in this situation, then you can't use a stapler while you are in the stomach, but you can also use a 12 mm stapler within the stomach and we can resect this. But in the stomach, it will be difficult to open the stapler. We won't get that leeway. So it's better to use a harmonic and do a resection and do a reconstruction by suturing technique of the stomach.
One more technique which we can we can use here is endoscopic localization, intra-op endoscopy localization, and then do either of the things which we talked about earlier. In lesions which we are not able to see, smaller lesions from outside, and if methylene blue has not been injected earlier, we have often resorted to this endoscopic localization. So you don't have to do an anterior gastrotomy, and the same area which you are going to resect, you can either staple or suture, whatever you prefer, and just saves a little more time. I mean, you don't have to close the gastrostomy. So that's also one of the good options which you can do.
So if somebody is using an intraoperative endoscopy, I would strongly recommend that use very little insufflation and use carbon dioxide, not air, which normally we use. We should not use air because that will cause a lot of distension and will hamper the laparoscopic view.
Good, sir. Now, Dr. Nikhil, can you move on to the next slide? Next. So this we already discussed laparoscopy versus open surgery. My next question is to Dr. Anand Narayan. How much margin would you prefer to take in this surgery, Dr. Anand?
So, so in GIST, we usually take microscopic margin around 1 to 2 centimeter, and that will be most of the time sufficient. Our target is to achieve R0 resection. We do not like in adenocarcinoma where we take a larger margin in GIST. We are only concerned about the R0 margin, and 1 to 2 centimeter gross margin is enough.
I think there is no confusion regarding in this case, as already have been described by Dr. Sanjiv Haribhakti, that smaller tumor, you just need a 1 to 2 centimeter R0 resection is enough for in this case. So my next question to Dr. Premananda is that what do you think about the role of lymphadenectomy in GIST tumor, or particularly in this case?
There is no role of lymphadenectomy in GIST if there is no lymph nodes enlarged in CT scan, because the lymph node metastasis is very, very rare in GIST. So particularly in this case, it's not required.
Good. I would like to add that if in case of GIST, if there is no gross lymphadenopathy, we don't need any lymphadenectomy. But if there is any lymphadenopathy on any investigation, then we have to go for lymphadenectomy for that particular lymphadenectomy. Next slide, Dr. Nikhil.
May I ask a question?
Yeah, please.
So, like you did the endoscopic ultrasound in this case. So, my question is to Sir, Dr. Sanjiv, sir. Sir, do you do endoscopic ultrasound in all patients with smaller tumor, 2-3 centimeter size of gastric cyst?
So EUS is only done if you want to take a biopsy. We don't do EUS routinely because upfront the treatment is surgery. You don't need a EUS for GIST unless you want to conserve this GIST. If it's a small tumor you want to conserve, then you want to make sure that it is a homogeneous. It does not have any necrosis, hemorrhage, those things. It does not, there are no high risk group factors. You want to take a biopsy. You want to confirm that it's a low risk. Mitotic index is less than 5. So that's when you need a US. Otherwise, US is not needed in GIST.
So I will have a small comment here. Our gastroenterologists will routinely do EUS in smaller GIST because they have now actively started doing this ESG
EMR.
and all these procedures.
Yes.
Yeah, EMR. So they look at the origin, and if the propria is free, they do endoscopic resection, obviously in smaller GIST. So now that has become a standard part of management protocol for at least like what our practice is currently. Right. So that's one of the approaches.
No, but I don't think that EMR or ESD is indicated in GIST. What you need in GIST is what is called as a FTR, a full endoscopic full thickness resection. That is what you need in GIST. In GIST, you can't do a EMR or a ESD because it's not just a submucosal tumor. So one needs to resect it completely. It's a full thickness resection.
agree. So I think we can have this discussion here. So I'm asking question rather than commenting. So if you can see it on endoscopic ultrasound that your muscle layer is free, or you can do that with a good margin over there, at least like if it's from a muscularis, no.
No, because these tumors arise from the muscles. So you can't get a clear margin.
So sir, our gastroenterologist says that if the tumor is rare, well, it's not common, arising from the muscularis mucosae,
Propria.
from the muscular propria, in those selected cases, not very common, on a small tumor, they can do safely EMR. But in most of the cases, they can't do irrespective of size of tumor. I agree with you, sir.
Yeah, Dr. Suresh.
My next question to Dr. Basant, what other precaution you would take while handling this tumor during surgery? Actually, everything has been discussed by Dr. Sanjiv Haribhakti in very nice way. So,
the only thing, as sir has pointed out in his presentation, that we should be careful while handling the tumor, that we don't breach the capsule. There should not be any perforation of the tumor, because it can lead to recurrences. And while dissecting the tumor, if this is at favorable location, we can easily get a 1 or 2 centimeter margin. The problem comes when these tumors are at unfavorable location, near the G junctions, or near if you are having erectile G's near the sphincters and all, there the problems of margin come, and then we have to weigh our options, whether we want to go for organ preservation or a margin. So that is where we have to be careful. Otherwise, in the favorable location, you easily get 2 centimeters.
So this means we have to do a minimal handling. If we are doing a laparoscopy, we have to use a bag. If we feel that tumor is large and difficult to handle by laparoscopy, then we can convert the procedure into.
Yes.
One thing is during laparoscopy, when you are handling the tumor, one should not touch the tumor directly with the laparoscopy instrument. What one can do is they will handle the tumor with the peritumoral tissue, which is away from the tumor. So that can be used as to hold the tumor indirectly. One should not directly hold the tumor surface with the instrument.
Next slide, Dr. Nikhil. So in this case, we have done a laparoscopic sleeve resection, and the tumor is seen along the more on the greater curvature. So sleeve section has been done. Next slide, Dr. Nikhil. The final biopsy of this tumor is size 2.8 into 1.8 centimeter, and mitotic index is less than 1 per 50 hair field, and IHC positive for CD117 and CD34. My question to Dr. Alok Ranjan. Sir, what do you think? What is the next step we should do in this case? Dr. Alok Ranjan.
As size is 2.8 into 1.8 centimeter, and mitotic index is less than 1. It comes in good, low risk, and hence only observation is required.
Yes. So I in detail described Dr. Sanjiv the NIH modified NIH classification. It comes under the very low risk category. So in this case, we have to just observe this case. Next slide, Dr. Nikhil. Next slide. So this is again NIH classification that described Dr. Sanjiv Haribhakti. According to this tumor comes in the low risk category. So we are going to observe this case. Next slide. My next two cases are just to show that tumor at the various sites and how we can handle these tumor. In these cases, just the surgical principle remain the same, that you have to do the segmental resection. You don't need to do a lymphadenectomy, and you have to handle the tumor minimally. So my next case is 65-year-old male. He's a known case of diabetes and coronary artery disease. He presented to us with a chief complaint of melena. He was initially evaluated with upper GI scopy and colonoscopy, and it was found to be normal. Then CT angiography was done, and it showed a lobulated enhancing mass in the mid-jejunum, and it was suggestive of GEST. Next slide, Dr. Nikhil. In this case, we have done a segmental resection, and anastomosis. So just showcase this tumor to show that at various sites, our surgical principle remains the same. We have to do segment resection, and then we have to see whether it comes in the high risk category or low risk category. Then we have to plan our adjuvant treatment accordingly. Next slide, Dr. Nick. Next case is 64-year-old male. He had a road traffic accident, and he came to the emergency, and he was evaluated with CT abdomen and showed us some enhancing lesion in the terminal ileum, which is suggestive of some gist. And he never had any prior history of pain, abdominal vomiting, constipation, like that. Next slide, Dr. Nikhil. So in this case, again, we had done a limited right hemicolectomy. And next slide, Dr. Nikhil. Now coming to the case.
Dr. Suresh, before you move on to this, I have a couple of questions in my mind which I would want to discuss. One, we should be very clear about the role of biopsy. So, Sir Dr. Sanjiv, like if it is a tumor which looks like a gist and it is more than 2 centimeters, and if we are not planning neoadjuvant treatment, would you biopsy these lesions?
No, there is no need to biopsy these lesions. We can go upfront for surgery, because in any case, whether it's a leiomyoma, sarcoma, or a gist, in any case, we would need to resect these patients. So for an operable lesion more than 2 centimeters from stomach, from the bowel, we don't need to biopsy. Actually, with the percutaneous biopsy, there'll be a slight risk of tumor dissemination. And with the endo ultrasound biopsy is quite safe, EUS guided biopsy, but still, it does not alter the management plan. Because in any case, it will be better to do an IHC from the primary tumor rather than the EUS biopsy.
And what about smaller tumors?
Smaller tumors, if you are going to leave it behind, then definitely we need to biopsy them, because then if it's an NET, then probably they may need a surgery. If it's a gist, one can observe. So I think if you are going to conserve this patient, then biopsy would be necessary. If you are going to give neoadjuvant treatment, histopathology is mandatory, because you need an IHC diagnosis to give neoadjuvant treatment.
Right.
So on both spectrums,
I just wanted to
you need a biopsy. Yeah, from both
yes,
the
yes. So I think,
yeah,
I mean, just wanted to bring this point out that for less than 2 centimeter lesions, only biopsy is required, but more than 2 centimeter or lesions where we are not planning to give any neoadjuvant treatment, upfront resectable, there is no need for a biopsy. We shouldn't even attempt biopsy, because just are very prone to rupture, and like during biopsy or surgery, disseminating just, I call it a cardinal sin. That's the worst you can do to a patient. From a curable disease, we can make it an incurable disease, or at least just a metastatic disease. So that's one. And I think there are a couple of more points which I will ask in this case, Dr. Suresh.
So my question is regarding the third case that Dr. Suresh showed, that ulcerated small bowel tumor which presented with the melena. Now 5 centimeter lesion.
This one.
Yeah. Now this one, does an ulcerated gist represent a ruptured tumor? That is my question. Because it's an internal rupture. It's not outer rupture, but it's internal rupture. And we know that gist does not recur at the same location. It recurs at different location in the bowel. When we resect a jejunal gist, I have seen patients coming back with an ileal gist. So whether this would also mean that these are high-risk tumors and they definitely need an adjuvant treatment, that is the question.
Well, I'm not aware of any such data where you look at adjuvant where you have an internal rupture. Rupture, I mean, this is basically an ulcerated gist which was bleeding.
So ulcer is a rupture because it's a submucosal tumor. It's not a mucosal tumor. So when it ulcerates, it means it has ruptured inside, isn't it?
I get that. So you do have a valid point, but then I am not aware of any paper which have discussed this in the context of adjuvant treatment.
Right.
Dr. Nikhil, there is an article regarding this tumor. There is an article regarding tumor rupture in GIST. So in that article, they have mentioned intraluminal rupture, like this kind of thing, what Dr. Sanjiv sir told, the ulceration of the GIST. In that article, they didn't consider it as a rupture or spillage kind of thing.
Okay.
In that article, yes.
Interesting.
They have
Okay.
classified a lot of things, and particularly this kind of ulceration, they didn't consider it as a spillage, tumor spillage.
Okay.
So
Good point. Yeah.
adjuvant is not.
I think that answers our question. Dr. Suresh.
Now I'm coming to a very interesting case of gastrointestinal tumor. This is 32-year-old male came to us from Tanzania. He had no comorbidity, but he had a very large palpable mass in the abdomen, and he was having pain abdomen since 2.5 years. A previous attempt was done at their own country, but they were failed to do surgery. Next slide, Dr. Nikhil. Then he came to us for further treatment, and we have done a CT angiography, and it showed a very large mass arising from the pelvis, which is quite indistinct from the rectum, and it is pushing the bladder and ureter, everything. And there is another mass that is seen in the left lobe of the liver. Next slide, Dr. Nikhil. So this is just detail of the mass, that is a 28 into 17 into 10 centimeter mass seen in the arising from the abdominal pelvic area, and around 16 into 15 14 centimeter mass arising from the left lobe of the liver, and that various other details I've seen. Next slide, Dr. Nikhil. And on PR, when we had done a PR, the tumor is palpable 2 centimeters from the anal work, but the overlying mucosa of the rectum is normal and it is mobile. And this tumor is compressing the lumen of rectum. So my next question is to Dr. Sanjiv Haribhakti. Sir, this large mass arising from rectum with the possibly mets in the liver. Sir, what will be your next step?
So I like to do a biopsy. I like to do a staging, a PET CT, to look for the lungs, to look for the rest of the body, to get a histopathology first, and then I'll take it forward from there.
Sir, would you like to do a biopsy percutaneously or from rectum?
In this case, the option is that we can, if you want to do a percutaneous biopsy, it could be from the liver rather than from the primary tumor. That will also give us a diagnosis. If you want to take a biopsy from the primary tumor, then one can go through the rectum also, because if it is, but here, whether it's arising from the rectum or it's just compressing the rectum, we don't know. That is the issue. So it could be just, because of the huge bulk of the tumor, it may be just compressing the rectum. It may not be arising from the rectum. So that I think better is to go for, safer is to go for a biopsy from the left liver. It could be a CT guided TrueCut or an ultrasound guided TrueCut biopsy, and it will give us the diagnosis.
So in this case, we have done a percutaneous biopsy as we are not sure of the tumor, which kind of it is, and CT, and we have done a CT angiography along with CT chest, and biopsy is suggestive of GIST. So my next question is to Dr. Basant. So what will be your next step in this case, having a large rectal tumor with liver mets and biopsy is suggestive of GIST?
So since it is involving two organs, so kind of a metastatic GIST, so the best approach here would be, in my point of view, give him neoadjuvant imatinib and then assess for response. And probably we have to give them for 6 months or 8 months or so of imatinib.
Good. Dr. Nikhil, next slide.
So we will have a couple of questions here, and especially now I would want to bring Alok in the picture, because here sometimes we would differ with the medical oncologist, sometimes, I mean, depending on the patient and all that. So, Dr. Anand, would you want to do a mutational analysis here at this stage?
Yes. After biopsy, we definitely do mutational analysis for the KIT mutation and PTGFR alpha mutation. And if both are negative, then SDS mutation is must. If all are negative, then NGS is must. To confirm
Okay, so you will
other,
go stepwise.
yes.
Okay.
Sir, can you repeat it again? Dr. Alok,
Yes, yes.
sir, please repeat it again. What you said?
First KIT mutation, then PDGFR alpha mutations. If both are negative, then SDH mutation, the night dehydrogenase mutation. And then all are negative, then go for NGS to see other mutational status, such as BRAF, NTRK, and other mutation status. And meanwhile, also go for a staging of the tumor, and for a staging PET-CT or all regions CT scan if it's not available, and then proceed.
Would anybody differ from this?
Yeah, Dr. Nikhil, I just want to have opinion from the panel. See, it's a huge mass, and if we have done biopsy, confirmed the type of lesion or tumor it is just, and Dr. Sanjiv told we should go for a PET-CT, and we'll just test the disease. But if there is only liver mets and the tumor is, what is the tumor location? What we are seeing in the CT scan, it is only in the PET-CT. That is the tumor location, liver and the retroperitoneal. So what is the response of the neoadjuvant therapy in this setting? Whether this huge tumor can respond to the imatinib therapy significantly, I have doubt in my mind. So I think if we can resect it totally, because all the planes are intact, if we can resect it along with the liver mets without much of morbidity, then surgery should be the first option. I just have opinion from the panel.
I mean, if you ask my opinion, is that generally looking at the CT picture, I don't think that's a possibility.
Because all the organs are getting pushed away. It is not infiltrated by the tumor, right?
Yes, right, sir.
So this kind of tumor, you can easily resect it out.
So if you can easily resect, I mean, the hypothetical scenario you are telling, if you are easily resectable tumor where downstaging the tumor doesn't decrease the multivisceral or any morbidity of surgery, then obviously go surgery first. Correct, Dr. Sanjiv?
I think generally, this does not look like a easily resectable tumor. It's occupying the entire pelvis. It's occupying the abdomen, and it's pushing all the vital organs. You could see there is right hydroureter, hydronephrosis. It's going to be difficult to remove this tumor, and it's a metastatic lesion. So obviously, I think this is a good case for a neoadjuvant treatment. It is not a upfront resectable case. It is already somebody has tried before and has come out. And I think we should be wiser before just jumping into such an abdomen. And here we have a molecule which can give dramatic responses. With imatinib, you could see that in 6 months, the tumor can come down to 50% of the size. It is possible. You can have an excellent response. And then it will definitely be much easier to resect. And these patients will have a better outcome because here, of course, with imatinib, we know that over a period of time, these patients do develop resistance to imatinib, and then they may need sunitinib or regorafenib or something like that. But then, 6 months is a good period of time to see the natural biology of the tumor, its response to the adjuvant treatment. And then I think it will be much better and safer to resect these patients. At least 6 months, maybe even 12 months, I think, in a tumor like this.
I would concur with Dr. Sanjiv. And again, if we take this neoadjuvant treatment approach forward, so the next question which goes to Dr. Alok is that, so we have done biopsy, we know just, and you've sent it for mutational analysis. So would you wait for starting imatinib, or you'll start imatinib right away?
First, do mutational analysis, as all mutations are mutually exclusive. If each mutation are present, then definitely PDGFR alpha mutation will be negative. If both are negative, then go for SDH mutation. And if all are negative,
my question was that while waiting for the mutational report to come in, would you start with imatinib?
No.
How much time it takes at your place to get mutation analysis report?
About 10 to 15 days.
Dr. Alok, what is the
would need-
harm of giving imatinib in that 15 days?
Yes.
If we had diagnosis of GIST, I think by
Dr. Alok, like given the possibility that 80 to 90% of them are going to be responsive to imatinib, I don't think I would want to take that chance.
But there are certain tumors like SDH deficient tumors, wild type mutant tumors, they will not have any response to imatinib.
I totally get that, sir. But then 80% probability that it will respond, and 10%
right.
patients who will not respond, we are not doing them any harm.
Right.
And
So we can start imatinib while we are awaiting the results, and then we can change the approach based on the results.
And to add this, sir, sometimes even the biopsy will be insufficient. So we will add further time, further 2 weeks more.
Yes.
So I think better to start imatinib and go with the probability, high probability.
So surgeons don't agree with medical oncologists here. It's fine.
And sir, to add one more thing.
We are in majority.
like this patient, when it was opened in Tanzania, so what will be your preference? Intraoperatively, will you take biopsy or not? You have opened this, like Dr. Patnaik thought it's a resectable disease. You opened up, and there's a tumor in intraoperatively, thought, no, ureter is involved and you're not going ahead with resection. So should we take biopsy during surgery or not?
During surgery, one can take a true cut needle biopsy.
Yeah, true cut.
I think it is better to take biopsy.
One should not do an excisional biopsy.
Excisional biopsy
should be done. Should be avoided because that can cause tumor spillage.
Yes, sir.
Yeah, but at least a needle biopsy, true cut biopsy can be done.
Moreover, you could easily achieve any hemostasis also. We can take biopsy once we have opened the abdomen.
Now, one more question which comes into my mind when we talk about this neoadjuvant treatment. I mean, a lot of these patients would be coming to us with a CT scan. Now, if we want to give neoadjuvant, because some of these tumors are known to have not different kind of response assessment criteria on CT scan compared to other tumors. So the size doesn't always decrease. They will become cystic or they'll have decrease in heterogeneity. And similarly, to assess a rapid response, like suppose you don't have these mutational analysis facilities, or if the patient cannot afford them. So one of the ways of assessing response quickly is to do a PET scan at say 4 or 6 weeks, where it will very rapidly show decrease in FDG avidity. And even like when you are doing mutational analysis, so response assessment is better on PET scan in these patients. So a question is that should we do PET scan routinely in these patients, even if we have a good quality CT and chest CT scan, if we are planning neoadjuvant treatment?
So I think there's a recommendation by NCCN that PET scan should be a part of the routine workup for GIST, especially for this last tumor. So now they have accepted PET scan as a standard modality for investigation in GIST specifically. So because of the good, you get a lot of information from there.
Apart from size, apart from size,
what will you do in your practice? Would you do a PET scan despite a CT scan, or you'll go ahead with the imatinib?
Especially if you're giving neoadjuvant, definitely PET scan.
I think I had those questions. Dr. Suresh.
So Dr. Nikhil, please next slide, please. So I think we have already discussed this thing. This question is to Dr. Premananda, sir. We have already discussed the neoadjuvant treatment, Dr. Alok Ranjan. So what are the indications for neoadjuvant treatment? I just would like to anybody of you have to summarize what are the indications for neoadjuvant treatment?
When the disease is metastatic, when it is a huge tumor infiltrating into the adjacent organ, you want organ preservation. And these two are mainly the criteria to go for neoadjuvant therapy to preserve the organ and in metastatic disease.
So metastatic disease, it's not called a neoadjuvant treatment, it's a palliative treatment. Neoadjuvant will be done mainly for borderline resectable. So if it is upfront resectable, you don't use neoadjuvant. If it is unresectable, you use the palliative treatment. But if it is borderline resectable, then you use neoadjuvant treatment. Especially
So, Doctor, sir, I was actually going to ask this question next. Like say colorectal liver metastasis or metastatic colorectal disease. So in just, can we use the same methods? I mean, if we can achieve R0 resection, say with liver resection or peritoneal resection, or like there are multiple deposits in peritoneum, sometimes we see that, okay, they can be removed. So would you give neoadjuvant and go ahead with surgery later?
So you're talking of debulking.
No,
right?
I am talking of a possibility, like say, where we can achieve an R0 resection after downsizing them. So I'll give you a concrete example. Yeah, like there is a gastric cyst or a small bowel cyst with a lesion in liver.
Okay.
Which you can completely resect, R0.
Okay.
So would you go for that option or not?
Definitely, definitely. Even if you cannot do R0 resection, in GIST, there is a evidence, a body of thought, a school of thought which says that you can still do debulking and they will respond to adjuvant treatment or medical management much better. So there is.
I would want more clarification here. So debulking for a locally advanced disease like R1 resection versus a metastatic disease, would you make a distinction there?
Yeah, so that would depend on what is more symptomatic. Sometimes a local disease, because of the large bowel masses, causes obstruction. Sometimes they cause bleed if they ulcer into the. So definitely then you can debulk the local disease. Large metastatic disease, generally you would debulk only if you can improve the response to your medical management. And this also studies have shown that the response may be, especially the ones which are responders. These are the patients in whom, even if there is a metastatic disease, you could debulk the metastasis and give them a safely. If you could do this safely, then you can improve the survival for these patients also.
Yes. So I can give you one anecdote where we have done a resection in metastatic disease. So like some of the areas in the peritoneum stopped responding to imatinib, while rest of the peritoneum was responsive. So we went ahead and resected whatever we could, especially focusing on the areas which were no longer responding to imatinib, and that gave us some more survival time. So yes, we can do a lot of things there. Right. Dr. Suresh?
My next question, Dr. Sanjiv sir, would you like to consider neoadjuvant treatment in rectal cancer also?
And which cancer? Which cancer?
Rectal GIST.
Sorry, rectal.
Sir, GIST in rectum, sir. Yes.
Rectum. Okay.
When will you consider neoadjuvant treatment in GIST in the rectum?
So if it is in the intraperitoneal rectum, rectosigmoid, upper rectum, and if you can do a single one-stage upfront resection, segmental wedge resection of the rectum, then I would not consider neoadjuvant treatment. But different situation is different if it's a large tumor in the lower rectum, which is close to the sphincters, where you want to conserve the sphincters and you want to reduce the bulk of the disease, then definitely neoadjuvant treatment will be useful in this situation.
Sir, you mean if you can go ahead for a surgery without any sphincter disruption, then upfront surgery is okay. But if there is any issue with the sphincter preservation, then we have to give a neoadjuvant treatment.
Yes.
My next question to Dr. Basant sir, if there is a tumor in the duodenum, what do you think about giving neoadjuvant treatment?
In duodenum, so it all depends on which part of duodenum the tumor is in.
Sir, suppose it in a D2. Actually, I want to ask whether you will go for Whipple procedure if required, or you want to shrink this tumor and go for local resection.
By local resection, basically you're meaning ampulectomy, because we do Whipples only for tumors that are near the ampulla. So I don't know. I don't have experience. Basically, if the tumor is in the ampulla, better go for a Whipple's resection. Neoadjuvant therapy in that scenario, I don't think will help that much. So if the tumor is in the second part of the duodenum, averting the ampulla.
Suppose it is away from. Suppose it is a large tumor away from the ampulla.
Then I think we can do a sleeve resection in duodenum, maybe. Duodenum, second part, first part, you can get away with a sleeve resection, maybe. third, fourth part, we do a segmental resection. So all depends upon the location of the tumor with respect to the ampulla. So there are multiple factors which have to be considered. But neoadjuvant therapy in duodenum, I don't know, sir, would given like I've never seen.
My question like that: if tumor is away from ampulla, but if you are planning to do a surgery and it compromises the lumen of duodenum, then will you think of giving neoadjuvant first, then surgery, or
as I told you before, it will all depend upon which part of the duodenum the tumor is in, how, and then you have to plan the surgery. So D3, D4, D1, you can easily do resection. I don't think there should be much of a problem. So the problem would be the tumors in the ampulla, encroaching upon the pancreatic head. And there, I think better option to do a Whipple surgery there. You might require a Whipple surgery there.
I guess what Dr. Suresh is trying to ask is that if we can decrease the magnitude of resection, like say for an example, if a large tumor in D2 or D3, which would require Whipple, but if you decrease the size of the tumor, then you can probably get away with a sleeve resection. So then I don't think this recommendation for neoadjuvant treatment anywhere differs from the site of origin. Like if you can decrease the magnitude of surgery, any multivisceral resection, or if you can do any organ preserving surgery by decreasing the size of the tumor, then we should go for neoadjuvant treatment.
Yes.
Correct, sir? Dr. Sanjiv?
Hello, Dr. Suresh, I can't hear you. Hello.
I think so.
Yes, sir.
Suresh can't hear you. Yeah.
Sir, Dr. Nikhil, can we go to the next slide?
Yes, yes.
The question is for Dr. Alok Ranjan that already we had discussed that after getting this biopsy and it's a GIF, then it's a large rectal tumor with the liver mets. So next step is probably, I think, neoadjuvant chemotherapy, and it's a tyrosine kinase inhibitor we have to start. And in this patient, we have started imatinib 400 mg OD. Next slide, Dr. Nikhil. My question to Dr. Premananda sir, when would you like to assess the response to tyrosine kinase inhibitor after starting the imatinib? I mean, when would you like to get a CT scan or PET CT, and how will you approach to assess the response to the tumor, tyrosine kinase inhibitor?
So in this kind of patient, if you have started neoadjuvant therapy, then better option is to go for PET CT scan, where you can see the metabolic response apart from the tumor size reduction. If you see the metabolic response, that is one of the criteria in GIST, where you can see the response to the neoadjuvant therapy. So I think after 3 months of therapy, one should go for PET CT scan, and there should be a baseline PET CT before starting neoadjuvant.
Dr. Sanjiv, what would you like to say about this? Would you like to do a PET CT scan, or you can repeat CT also, sir? What is your opinion?
So I think for a very advanced tumor or a metastatic tumor, we would definitely do a PET CT baseline. To assess the response to treatment, I don't really think that the metabolic response is going to help me so much. I would rely more on the size reduction and the RECIST criteria to see for the response to the treatment. And I would rely more on CT scan because ultimately the idea is to resect the tumor. And this, I would do it at 6 months, not earlier, because at 3 months, we may do an ultrasound and see the response to the size. And then see at 6 months, we can do either a CT scan or a PET CT scan. Both are the options. But I think in a majority of the situation, if it's a localized tumor in the abdomen, no other extra abdominal disease, and PET CT has already shown, then I don't think that metabolic response, in terms of FDG uptake, will really make a difference in the treatment. It may tell you about the response, but it's not going to make a material difference in the treatment outcome. And that's why I feel that a CT would be sufficient to know the reduction, and then one can plan to go ahead for the resection.
Sir,
I mean, sir, I would beg to differ slightly here. Like if the patient is not responding, which we assess by, say, a CT scan or a PET CT scan. So CT scan sometimes will not show decrease in size. It will show only the decrease in the density of the tumor. So if the patient is not responding to imatinib, in that case, I wouldn't want to wait for 6 months. I would rather resect early and do a multivisceral resection if required.
Or maybe change over to another drug.
Or maybe change over to another treatment. Yeah.
Second or third line.
Especially if the mutation analysis is not there, so we can change the dose, we can change the drug. So in those cases, maybe the PET CT will score over the CT, and this PET CT can be done early, maybe 6 to 8 weeks even after the starting of treatment, to look for the metabolic response. That's one benefit of PET CT.
I think that's a very valid point. And Suresh, I would suggest that you wind up. Because
Sir, I will go quickly to the next slide, Dr. Nikhil.
we will just wind up, Suresh, leave it. We've discussed most of the things. And if you have any specific point, then we can ask. I think 6 months is also covered, 6 months to a year.
Yes, sir. Next.
Right. And
mutation analysis study we already discussed.
Yes, yes. So this we've discussed in the last webisode. So if somebody wants to understand this part of the discussion, we can just refer to our last webisode. It's all the recordings are available, right? And I guess you resected this. You can show this, and then we can conclude.
Left lateral segmentectomy with the intersphincter section. We have done this with the divergent ileostomy, and after 6 months we have closed the ileostomy, and patient was put on imatinib for 2 years.
So this 2 years, 3 years thing and the dosing and all that has been discussed in the last webisode. And whosoever wants to understand that can refer to that. And I have just 2 questions from the audience, which I will just quickly take, and then we can finish. So Dr. Praveen has asked, if a gastric cyst is involving transverse colon, can we go for neoadjuvant or multivisceral resection? Though this has been answered, but Dr. Anand, you can take up this question and answer.
So we can go as a upfront surgery, but if the is away from the pancreas, and yeah, but mostly if there is no any indication of urgent surgery, we will give the neoadjuvant, and then we'll go for the gastostomy or with or without part of colectomy, secondary colectomy.
Yes. And there's one more question. Like if we have given imatinib as neoadjuvant for say 6 months, so adjuvant will be 3 years or 2.5 years? Dr. Alok?
2.5 years. That is pre-op and post-op should be at least 3 years.
So you are sure about it. So I mean, exactly same question was asked in the last webisode, and there it was like obviously medical oncology heavy webisode. So we were in minority and they were in majority. So there, I mean, there was disagreement. Some people said we'll give for 2.5 and some said 3, but it's okay. I mean, fine. So there is this answer. So we'll take it 2.5. Fine. Dr. Suresh, do you have anything to add here now?
So Dr. Nikhil, after how many months of neoadjuvant you have gone for surgery in this case? How many months?
Suresh?
What, sir?
Dr. Suresh will tell you about that.
What, sir?
Dr. Suresh, how many months you have given imatinib in this case?
In this patient, sir, we have given 2 years. After that, he is not.
Neoadjuvant.
In this case, sir, we have given only for 3 months. Patient was having an unbearable pain, so we decided, as tumor looks resectable both for primary as well as metastatic, so we decided to go ahead with surgery.
So what is the size reduction after 3 months?
It's very minimal, so not that much.
Very minimal. That's what.
Yes.
Okay.
Okay. You're done?
We are covered.
These things, yeah.
This
yeah.
question we can ask from Dr. Alok Ranjan, sir, whether we have to give 400 mg or 800 mg imatinib as adjuvant or neoadjuvant setting.
If exon 19 is mutation present, then give 800 mg. Otherwise, 400 mg.
400. Okay. I think we can find.
I think that sums up everything. So thank you very much. Thank you, Dr. Sanjiv. Thank you, Dr. Basant, Dr. Anand, Dr. Premananda, and Dr. Alok. It was wonderful as always. And sorry for keeping you away from your dinner table for so long. So with this, we conclude the session. We'll update you about the next one, what we are doing. It will be after 2 weeks. Thank you, everyone. Good night.
Thank you.
Thank you, Suresh,
Thank you.
for a wonderful panel discussion.
Thank you.
Good night.
Good night.